Imagine you beat cancer, right? You ring the bell, you're cancer free. But then you wake up the next morning and realize your cardiovascular system and your skeletal structure have basically aged like 15 years overnight.
Yeah, it's a terrifying reality for so many.
Oh, right. You've been plunged into this permanent, severe medical menopause without a single day of warning. So, welcome to today's deep dive. We are looking at a really dense but honestly fascinating stack of sources today.
We've got clinical oncology data, reproductive research, and the latest guidelines from both the British Menopause Society and the American Society of Clinical Oncology.
Exactly. And our mission today is to figure out exactly how these life-saving drugs catch the female body in this biological crossfire. Like
Yeah.
what actually causes medical menopause and the science of how treatments like chemotherapy trigger this sudden biological shift.
Because it is a profound disruption to the body's timeline. Most
Right.
people understand natural menopause as this gradual winding down.
Right, a slow transition.
Yeah, the body gives the cardiovascular and skeletal systems this multi-year runway, usually 1 to 3 years in the perimenopause phase, to just adapt to declining estrogen levels.
But medical menopause or premature ovarian insufficiency, it just strips that runway away entirely. It halts ovarian function abruptly, usually before a patient even turns 40 or 45.
Okay, let's unpack this because the suddenness is what makes it so destructive.
It really is. Like, if natural menopause is like slowly taking your foot off the gas pedal over a few years, medical menopause is, well, it's slamming on the emergency brake at 60 miles per hour.
That is a perfect way to describe it.
And the triggers are entirely external, right? Sometimes it's surgical, like removing the ovaries. Sometimes it's pelvic radiation or driven by hormone blocking meds like tamoxifen. But the most complex trigger we see in these oncology papers is chemotherapy.
Yeah, and the physical whiplash of that emergency brake is severe. Because estrogen is so often misunderstood as just a reproductive hormone, patients are totally blindsided by the systemic fallout.
Right? It does so much more than just reproduction.
Exactly. Estrogen is a fundamental structural protector.
Yeah.
I mean, regulate bone density, it maintains the elasticity of your blood vessels for heart health, and it preserves muscle mass.
So when those levels drop to zero overnight,
It isn't just about getting severe hot flushes or, brain fog. It is a rapid acceleration of long-term cardiovascular disease and osteoporosis risks.
hmm,
You are suddenly dealing with an artificially aged internal environment.
wow. Which I guess brings us to the microscopic battlefield, because chemotherapy is engineered to hunt down and destroy rapidly dividing cancer cells, right?
Right. But it ends up devastating the ovaries in the process.
And diving into the clinical data, it all centers on this concept of the ovarian reserve, which is that finite pool of dormant resting eggs, the primordial follicles that a woman is born with. And the chemo attacks this reserve through three highly specific mechanisms.
Right, so the first mechanism is just a direct assault on the DNA of the oocytes themselves. Chemotherapy drugs actually infiltrate the resting egg cells and cause double-strand breaks in their DNA.
Wow.
Yeah. Now, the eggs do possess this innate internal repair machinery. They deploy proteins, specifically one called RAD51, to try to fix those fractures.
Right. The sources say Rad 51 acts less like a doctor and more like a biological welder, desperately trying to fuse the broken double strands of DNA back together before the cell's whole structural integrity collapses.
Exactly. But when the welding fails, because, the chemical bombardment is just too heavy,
Mhm.
a secondary protein called TAP63 takes over.
And that's the bad news protein, right?
Well, TAP63 basically functions as a self-destruct mechanism. It initiates apoptosis, which is programmed cell death.
Oh, wow.
The evolutionary logic here is brutal, but necessary. The female body essentially decides that an egg would rather destroy itself entirely than risk surviving with mutated DNA.
Because that could result in severe fetal abnormalities down the line.
Ex-
I mean, that direct toxicity makes intuitive sense. You poison the system, the fragile cells die. But the second mechanism in the research is entirely counterintuitive. It's this physiological domino effect they call the burnout effect.
yes, the burnout effect.
To grasp this, we kind of have to look at the daily state of the ovaries. At any given moment, only a tiny fraction of follicles are active and growing, right?
Right. The vast majority are dormant. They're kept asleep by a chemical stop sign called anti-Müllerian hormone, or AMH, which is produced by those few active follicles.
So as long as those active follicles are producing AMH, the dormant reserve knows to just stay asleep.
Yes. But chemotherapy is highly lethal to active growing cells. That's its main job. So it sweeps through and obliterates that small percentage of active follicles almost immediately.
And with those follicles gone, the AMH production just plummets to near zero.
Exactly. The chemical stop sign simply vanishes. And without AMH, the brakes are completely removed from the dormant reserve.
Right, which triggers a panic signal via this biological route called the PI3K pathway.
Yes. And it causes a massive accelerated awakening. Thousands of dormant eggs stampede out of the reserve, all starting to grow at the exact same time.
Wait, so the chemotherapy isn't just poisoning the sleeping eggs directly, it's accidentally tricking them into waking up all at once, only to be wiped out?
Yes.
That's tragically fascinating. They wake up, become active, and then are immediately slaughtered by the ongoing chemotherapy.
What's fascinating here is that it's an induced stampede. The chemotherapy literally forces the ovary to burn through its entire lifelong reserve in a matter of months. And understanding this specific PI3K pathway isn't just an academic exercise.
Right, it has real applications.
Exactly.
Yeah.
Identifying this exact molecular burnout is what allows researchers to develop targeted therapies to block that pathway, which we will get into shortly.
Okay, but even if an egg somehow survives the direct DNA damage and avoids that PI3K burnout stampede, it still isn't safe, is it?
No, it's not.
Because the third mechanism shows that chemotherapy doesn't just attack the cells, it torches the environment they live in. It causes profound vascular damage,
All right, the drugs induce fibrosis.
which basically thickens and scars the blood vessels in the ovarian cortex. And that drastically chokes off the blood flow, starving whatever surviving tissue is left of oxygen and nutrients.
Leaving the eggs in a heavily compromised hypoxic wasteland.
It's just devastating. So, knowing those three mechanisms, the DNA breaks, the burnout stampede, and the vascular starvation, that explains the damage. But a major question in the clinic is why some patients get their menstrual cycles back after chemo and even go on to have successful pregnancies, while others on the exact same treatment go into permanent medical menopause.
Right, and the clinical data points to three main variables for that: the patient's age, the specific drug class, and the dosage regimen.
Age is simply a matter of biological math, right? Women under 40 naturally possess a much larger reserve of dormant eggs.
They have a bigger bank account to draw from.
Exactly. When the chemotherapy triggers that burnout stampede, they lose a massive portion of their reserve, leading to temporary amenorrhea where their cycles stop. But because they started with such a high number, they often have enough dormant eggs left over to resume normal function once the chemical assault ends.
Conversely, a woman over 40 already has a diminished natural reserve. Applying the exact same chemotherapy regimen to a 42-year-old that you gave to a 28-year-old yields a completely different outcome.
Because she just doesn't have the numbers.
Right. The 42-year-old simply doesn't have the numbers to survive the PI3K stampede. Her reserve is depleted past the point of return, rendering her permanently menopausal.
But the variation in the drugs themselves is just as stark. The sources highlight the difference between alkylating agents and antimetabolites. Alkylating agents, like cyclophosphamide, are essentially biological carpet bombs. They are incredibly toxic to everything they touch, destroying both dividing cells and those resting dormant cells by causing cross-linking in the DNA strands that is just nearly impossible for those RAD51 proteins to weld back together.
Whereas antimetabolites, like methotrexate, they operate with much more precision. They interfere with the enzymes necessary for DNA synthesis, which means they primarily target cells that are actively trying to divide.
Sparing the resting ones.
Exactly. They largely spare the resting dormant cells in the reserve, which results in a significantly milder impact on long-term fertility.
And obviously, adding radical multi-agent chemo regimens into the mix compounds the damage compared to single-agent therapies. But if you're a patient staring down a chemo regimen, how do doctors even predict if you'll go into menopause? It can't just be a guessing game.
Oh, it's not a guessing game anymore. Doctors track the biological math by constantly testing AMH levels. Monitoring that anti-Müllerian hormone before, during, and after treatment provides a real-time window into the health of the ovarian reserve.
So a sharp drop in AMH is basically the canary in the coal mine.
Exactly. It signals severe depletion, guiding those critical conversations about fertility preservation before the treatment even begins.
Which creates a terrifying pivot point for the patient. Because once the reserve is depleted and medical menopause sets in, patients, especially those recovering from estrogen receptor-positive breast cancers, they face an agonizing clinical paradox.
The symptom paradox.
Yeah. The precise treatments required to ensure their cancer does not return make managing the severe menopausal symptoms incredibly difficult. To starve any microscopic remaining cancer cells, patients are prescribed adjuvant endocrine therapies.
Right, drugs like tamoxifen actively bind to estrogen receptors, blocking them.
While aromatase inhibitors completely shut down the enzyme that converts androgens into estrogen in the body's peripheral tissues, so you have a patient whose ovaries have been shut down by chemo, now taking daily medication designed to eliminate every last trace of systemic estrogen.
It's a double hit. And the hot flushes, the severe joint pain, the genitourinary atrophy, the insomnia, all those symptoms are amplified to an extreme degree.
And in a natural menopause setting, the gold standard treatment is systemic hormone replacement therapy, or HRT. You just replace the estrogen to relieve the symptoms.
Right. But in an oncology setting for an estrogen-driven cancer, giving systemic estrogen is considered an unacceptable risk for triggering a recurrence. It is off the table entirely.
It's like your internal thermostat is broken and your house is freezing, but because the central heater is known to cause devastating fires, you are absolutely banned from turning it on.
That's exactly it.
You have to find totally different ways to warm up the house, and that forces a massive shift in symptom management, relying heavily on off-label drug use.
Right. Doctors are prescribing medications engineered for completely different conditions because they just happen to neurologically treat menopause symptoms.
Like antidepressants.
Yes. Selective serotonin reuptake inhibitors like citalopram or SNRIs like venlafaxine.
Mhm.
And they are not being prescribed here to treat clinical depression.
Right.
They are prescribed because they modulate the serotonin and norepinephrine pathways in the hypothalamus. And since the hypothalamus is the brain's temperature control center without estrogen, it misfires wildly, triggering severe hot flushes. Modulating those neurotransmitters stabilizes the thermostat.
That's so clever. And the use of gabapentin is another brilliant example of off-label mechanics. Originally developed as an anti-seizure and nerve pain medication, gabapentin alters calcium channels in the brain.
Which suppresses those overactive neural pathways.
Exactly. It effectively resets that broken neurological thermostat to drastically reduce hot flushes, while simultaneously calming the severe, debilitating joint aches that are a hallmark side effect of aromatase inhibitors.
There's even oxybutynin, which is an anticholinergic drug designed for overactive bladders, being utilized because it blocks the specific receptors in sweat glands, stopping the drenching, sleep-destroying night sweats.
Wow. But beyond the pharmacology, the guidelines also heavily emphasize lifestyle interventions.
If we connect this to the bigger picture, it has to be holistic. Cognitive behavioral therapy, or CBT, is deeply emphasized, not just for the psychological toll, but because CBT has proven neurological efficacy in helping the brain reprocess and physically turn down the intensity of hot flushes.
And weight-bearing exercise transitions from just a general health recommendation to a non-negotiable daily requirement.
Right, to mechanically stimulate bone regeneration in the absence of estrogen.
Now, there's also a major warning in these oncology guidelines regarding herbal or so-called natural remedies, because patients who are desperate for relief often turn to over-the-counter supplements like red clover or black cohosh.
Yes, and the sources strongly discourage this for breast cancer survivors.
Because these plants contain phytoestrogens, which are compounds that structurally mimic human estradiol.
Exactly. Once in the body, they can still bind to and stimulate those estrogen receptors, potentially feeding dormant cancer cells.
Mm.
In an oncology setting, natural absolutely does not equate to safe.
Managing that aftermath is just a massive, delicate balancing act of treating the neurological root of the symptoms without introducing systemic hormones. But the research pushes beyond just managing the wreckage. The field of oncofertility asks a more ambitious question. How do we physically and chemically shield the ovaries during the biological crossfire?
Right, well, the chemotherapy is actively destroying cancer cells.
Here's where it gets really interesting. The first line of defense involves deploying GnRH agonists.
Medications like goserelin or leuprolide?
Yeah, these drugs actively suppress the pituitary gland, shutting down the hormonal signals that drive the menstrual cycle. They basically force the body into a medically induced prepubertal hibernation.
And by chemically silencing the ovaries, a crucial physiological change occurs. The blood vessels supplying the ovaries actually constrict.
They shrink.
Yes, they narrow down, drastically reducing the volume of ovarian blood flow. This provides a physical shield. Because less blood is flowing into the tissue, a significantly lower concentration of the toxic chemotherapy drug can physically reach the ovarian reserve.
Wow. You are minimizing exposure by choking off the supply line. But the research gets even more molecular, tying directly back to that PI3K burnout stampede we talked about.
Right.
If the chemo kills the active follicles, causing the AMH stop sign to vanish and triggering thousands of dormant eggs to wake up and rush to their deaths, can science just build a chemical barricade to hold them back?
That is the exact mechanism behind testing MTOR inhibitors, like everolimus.
Oh, interesting.
Researchers are using these drugs to intentionally intercept and block the PI3K signaling pathway. When the AMH levels plummet and the panic signal goes out, the MTOR inhibitor acts as a deadbolt.
That's incredible.
It physically blocks the signal at the cellular level, forcing the dormant follicles to stay asleep and remain in the reserve, entirely unaware of the chemical chaos happening around them.
The ingenuity there is staggering. We are chemically commanding an organ to play dead, barricading the doors at the cellular level so we can survive a systemic poison.
It really is amazing. Now, alongside this in vivo protection, the standard practice remains cryopreservation, freezing eggs, embryos, or ovarian tissue. But the timing, dictated by the guidelines, is absolute.
Right. You must harvest and freeze before the chemotherapy begins.
Exactly. Stimulating the ovaries to harvest eggs during or immediately after a chemotherapy regimen is highly contraindicated. It comes down to the mutagenesis we discussed earlier.
Because the active chemotherapy is causing massive double-strand DNA breaks.
Yes. If you force an egg to mature and be fertilized while it is swimming in a mutagenic environment, the risk of severe fetal malformations and miscarriages is just unacceptably high.
The ovaries require a significant washout period. The internal repair machinery, those Rad-51 biological welders, they need months of completely chemical-free time to meticulously fuse the broken DNA strands back together before those oocytes can be considered safely viable again.
The sheer resilience of the female body under this level of systemic toxicity is remarkable. This field requires constant, rapid adaptation, learning how to preserve a patient's endocrine health, their bone density, their cardiovascular future, and their fertility, all while actively deploying the most aggressive life-saving toxins we have.
It really does. Navigating the biological crossfire fundamentally changes how we view survivorship. It's no longer just a binary outcome of surviving the cancer. It is about intricately managing what the body retains after the battle is won.
Absolutely.
From understanding how drugs like cyclophosphamide accidentally trigger a fatal cellular stampede, to utilizing nerve pain medications to hijack a broken internal thermostat, to deploying MTOR inhibitors as microscopic barricades. We appreciate you taking the time to explore this complex stack of research with us today.
As a final thought for you to explore on your own, consider the potential of that internal repair machinery. Currently, our best oncofertility defenses involve putting the ovaries into temporary hibernation, erecting chemical barricades, or removing the eggs entirely to freeze them.
Right, purely defensive moves.
Exactly.
Right.
But we know those oocytes possess the Rad51 protein. They have the innate ability to weld their own DNA. What if, in the near future, we could develop a targeted therapeutic that doesn't just pause the system, but actually supercharges the egg's innate repair mechanisms?
Oh, wow. A drug that allows the eggs to heal double-strand DNA breaks on the fly, faster than the chemotherapy can cause them.
Right. If we could achieve that, we could render medical menopause completely obsolete. Patients could undergo radical curative chemotherapy without losing a single day of their reproductive lifespan, walking away from cancer with their internal timeline completely untouched.
What an amazing thought to leave on. Thanks for taking the deep dive with us.